So, today we're diving into one of the toughest and, frankly, most important challenges in healthcare right now. How in the world do you measure a mental health crisis? It's a question that doctors, hospitals, and whole health systems are trying to figure out. And for the people at the center of it all, well, the stakes just couldn't be higher.
And really, it all boils down to this one single question. Can a simple questionnaire, a checklist of thoughts and feelings, can that piece of paper actually save someone's life? It sounds like it should be a simple question, but as you're about to see, the answer is anything but.
All right, so before we can even get into the solutions people are proposing, we first have to wrap our heads around the core problem that clinicians are up against every single day.
Think about it for a second. A doctor can take your blood pressure, right? They can check for a fever. Those are objective tools for objective measurements. But mental health? We're talking about someone's inner world, the most personal, complex, and subjective part of being human. And it's this huge challenge, trying to create a ruler for our inner lives, that has pushed the search for new tools and systems.
And in response to that challenge, the healthcare industry has really started to rally around one big idea, a solution that is picking up some serious steam.
It's called measurement-based care, or MBC for short. Now, the core idea here is to start treating mental health a lot more like we treat physical health. Just like a heart doctor would systematically track your blood pressure to see if the medication is working, MBC uses data from these patient questionnaires to track symptoms and guide therapy. It's a huge shift away from relying only on a therapist's gut feeling and toward bringing hard data into the room.
And the benefits they're promising, they're huge. For clinicians, the idea is that this makes them more objective, more effective. The argument is that MBC helps get diagnoses right, it helps you spot when therapy might be going off the rails, and at the end of the day, it helps build a more successful and ethical practice because the patient's own reported progress is front and center.
And look, this isn't some fringe concept we're talking about. These are the heavy hitters. Organizations like SAMHSA, the Substance Abuse and Mental Health Services Administration, and the Joint Commission, which is the group that accredits thousands of hospitals. They now officially recognize measurement-based care as a legitimate, evidence-based practice.
Okay, so to really see how this works where the stakes are, literally life and death, let's zoom in on a powerful, real-world example, trying to build a scale for suicide risk.
This is the Columbia Suicide Severity Rating Scale. It's a bit of a mouthful, so we'll just call it the C-SSRS. It is a very specific questionnaire, and its one job is to figure out a person's immediate risk of suicide. And it is used everywhere, in schools, on military bases, and in crisis centers all over the world. Now, what's really clever about this is the logic. You can kind of see how it's designed to work like a funnel. It starts really broad at level 1, with a general feeling, just a wish to be dead. And then it gets more and more specific, moving through the stages, thinking about a method, having intent, and finally having a specific, concrete plan. The whole point is to put a number, a quantity, on the level of immediate danger.
And this is exactly why an organization like the National Suicide Prevention Lifeline uses it. It gives their call takers a roadmap, a structured, standard way to have an incredibly difficult conversation. It gives them a clear path to follow when every single second counts.
So, the logic seems solid, right? And the application makes perfect sense. But this is where things get really complicated. This is where a massive scientific debate starts to flare up over what these tools can and can't actually predict.
In this quote, wow, he cuts right to the heart of the problem. A major paper from 2018 found that suicidal thoughts have very little to do with actual suicide deaths. In fact, it found that screening for these thoughts predicts death only slightly better than flipping a coin. And if that wasn't staggering enough, look at this number. Researchers found that up to 72% of people who died by suicide actually denied having suicidal thoughts the last time they spoke to a clinician. Let that sink in for a second. 72%. That means a screener looking for those specific thoughts would miss the vast majority of people who are at the highest risk.
So you're stuck in this impossible situation. On the one side, you have false positives. People who flag as high risk but aren't, and that puts a huge strain on mental health resources that are already stretched thin. But on the other side, you have the far more dangerous problem, false negatives. That's when the screener says everything is okay, giving everyone this false sense of security and potentially causing a clinician to miss the real warning signs.
So, to just quickly recap the scientific critique, review after review has shown that no scale is good enough at predicting suicide deaths. Splitting people into low risk and high risk based on their thoughts just isn't proven to work.
As we just saw, most people who are at risk won't even admit to these thoughts on a form. And maybe the most frustrating part, the tools we're using haven't really gotten any better in decades. So, if the science says these tools are this flawed when it comes to prediction, why is the push for them getting stronger, not weaker? That's the paradox we have to dig into now.
Because if you look at this timeline, the trend is it's undeniable. From the VA back in 2016 to major accrediting groups today, big institutions are increasingly making these measurements mandatory. It is becoming the standard of care whether the predictive science is really there or not.
And that forces us to ask a totally different question. If the real value of these tools isn't in predicting the future, then what are they good for? And to answer that, I want to tell you a quick story from one of our sources. This is about a boy named Omar.
So Omar was a teenager, and he was really struggling after his mom left. A therapist had both Omar and his dad fill out the exact same questionnaire about his symptoms. And the results? They were worlds apart. When the therapist put the two graphs side by side, Omar's father just looked at his son and said, "I had no idea." And Omar just started to cry. In that moment, that questionnaire wasn't predicting anything. It was a vehicle for communication. It gave Omar a way to finally show his dad how much he was hurting, and it opened a door for a conversation they desperately needed to have.
And maybe this Maya Angelou quote is the best way to sort of hold both of these truths at the same time. This whole push for measurement-based care, that's the field trying to do the best you can with the tools that exist right now. And all that scientific criticism, that's the field knowing better. That's us learning the deep, deep limitations of those very same tools.
And that's really where this leaves us. If these tools are pretty bad for prediction, but can be incredibly valuable for communication, then the goal can't just be to measure more things more often. The real challenge, the one that the entire mental health field is facing, is to figure out how we get better at doing better.